So I welcome all of you to the Andhra Pradesh Ophthalmic Society session in the APAO. We firstly thank the scientific committee for giving us an opportunity to present in this prestigious conference. So this session is themed on the future trends in ophthalmology in different specialties. So each one of us will be covering a topic, a subspecialty on how the future trends would be there in the next coming 5 years. So I would like to start the session.
Madhu, please go ahead.
Yes. So the topic I would be covering is evolving trends in cornea and refractive surgery. There are no financial disclosures. So if you see, the scope of this talk would be under the following headings. So the role of artificial intelligence, smart probes, and lateral flow devices in infectious keratitis. What is the future of transplantations going to look like, and how keratoconus management is going to change. And in refractive surgery, how flapless is the way to go, and lenticular procedures are going to slowly take over from flap-based procedures. So if you see this landmark study from Dr. Venkatesh Prajna sir's group from Arvind, they have done a multimodal deep learning for differentiating bacterial and fungal keratitis using a slit lamp image. So this was taken both from the clinical data model prediction and computer vision model prediction. So that becomes a multimodal model prediction, which is a very unique model of predicting the outcomes of a slit lamp image and predicting whether the ulcer is caused by a fungus or bacteria. So if you see the AI predictability in causing the ulcer, so this is the manual segmentation. This is done by an ophthalmologist, whereas this is the automation segmentation that is done by a computer. But still, despite of the best AIs in place, I want you to concentrate on the graph that is there on the right side. So if you see here, the black curve is the all experts combined. That is Indian experts and non-Indian experts combined together. If you see, that's the black curve. Non-Indian experts in diagnosing infectious keratitis, they are inferior. And when you see only Indian experts in differentiating between bacterial and fungal keratitis, they're far more predictable even than the all experts combined together. So I think still the clinical acumen and your differentiation will definitely have a role despite of the best AIs being in place. So it will only add to the value of the diagnostic power, but it will not take away the diagnostic power of the clinician. And you can see that Indians especially have a superior diagnostic thing when compared to other clinicians in the world. So that blue line is the Indian experts, that is far more predictive value when compared to non-Indian corneal experts. So next, coming to smart probes, this is again a revolutionary way of diagnosing and differentiating between fungal and bacterial keratitis. So probe in the sense is not a physical probe. It is nothing but a fluorescein, that thing that will go into the slide in place of a strain. So if you see here, this is the gram stain in above slides. And in the down, these are the probes that are used to differentiate. So in the first slide, you can see BSE1. So by the pattern of the staining of fluorescein, you can identify whether it is gram positive, gram negative, or fungi. Similar to the second smart probe BSE2, it can differentiate again from gram positive, gram negative, and fungi. So if you see BSE1, so if you have a smart probe of BSE1, it will have a high positive correlation with gram positive and fungus, whereas in BSE2, it will have a high predictability for gram negative bacilli. So in future, all you need to do is to take a corneal scraping, put both these probes, and automatically when you see under a fluorescein microscope again is not a fancy equipment. It's a regular microscope with a fluorescein light. And under that, if you are able to add this thing, you can easily identify which organism is the cause. Next is the lateral flow devices. This is very similar to our pregnancy devices. This is again from Arvind Eye Hospital, Madurai, from Dr. Venkatesh Prajna. So what here they have done is, once the swab is taken, they put it into the thing, the swab is inoculated into this radiometric analysis. So here you can see it differentiates between species of fungi. So you know that it is a fungal infection. Why it is important to differentiate between aspergillus and fusarium? Because fusarium is easier to treat. With your natosol, it works well, and if you do a correct treatment, by 2 weeks you see scarring. Whereas aspergillus is a very tough organism to handle, for which you need earlier diagnosis, where you may need to add intrastromal voriconazole, additionally voriconazole, and sometimes even systemic voriconazole to take care of aspergillus. Because aspergillus keratitis is the common thing that goes into corneal perforations or scleral involvement. So it's more important to identify which fungus is causing this, and in that I think lateral flow devices will have a role in future. So just to sum up the place of AI and machine learning in cornea and refractive surgery, based on only clinical data, forget about the slit lamp images also, classification between fungal and bacterial keratitis and prediction and need for keratoplasty is also there. Based on only on the size of ulcer, history, and all these things taking into consideration, there are now algorithms that can tell you when an ulcer presents to you whether this is going to require a keratoplasty in future or not. Not even an image, just the history, size, morphology. And slit lamp photography, you can definitely see, like in the previous studies, you differentiate between infectious and non-infectious keratitis, you identify corneal dystrophies, you identify surface neoplasms, you can distinguish bacterial and fungal keratitis as shown in the previous studies. Next, coming to ASOCT, it can detect localized mild corneal edema, it can predict graft detachment also in lamellar surgeries, especially DMEC, where we are doing more commonly now. So ASOCT images, if you are able to do a proper AI algorithm, by taking this images itself, you can know whether this DMEC graft is going to stay attached or it's going to require a rebubble. Okay, and also it helps you to identify early Fuchs corneal dystrophy. Next, coming to corneal topography and tomography, now there are a lot of algorithms that are already being used for detection and grading of keratoconus, and also outcomes of intrastromal ring segments, how the refraction is going to change. IVCM is not very practical for us, it's mostly used in institutes, but however, correlating to corneal nerve features, again it helps us to diagnose diabetic neuropathy that causes dry eye and assess its severity, and it also diagnoses fungal keratitis based on the fungal filaments that you see in the IVCM. Coming to refractive surgery, there are a lot of nomograms for optimizing outcomes in refractive surgery and IOL power calculation. And preoperative screening for corneal refractive surgery, identifying of corneas that are prone to post-CRS, ectasia also you can identify better. So these are already things that we are doing now. You have in your Pentacam series, all these things are already being done. So in cornea, few of them are there, few of them you are going to see in the next 5 years. So coming to keratoplasty, I think slowly the lamellar keratoplasty will be replaced by drug therapies. So now what is happening, retina in form of anti-VEGF therapy will be future, we will be having ROCK inhibitors and cultured endothelial cells. And stromal scars also you can regenerate by using stromal regeneration matrix. Keratoconus, early detection and cross-linking, so minimal surgical intervention would be required. So if you are planning to do cornea fellowship, all you need to learn is therapeutic keratoplasty that's going to stay, because infections still are challenging, and a penetrating keratoplasty, putting the 16 sutures is what would be required. And newer keratoprosthesis options are also in place, like alpha core, hybrid models, liquid cornea that are being developed. So if you see, I'll concentrate more on the endothelial disease, which is more clinically relevant. So if you see, what we were doing previously was PK, that was very highly invasive. Now most of us have adopted to DSEC or DMEC. So now the future trend would be tissue engineering therapy in a severe stage and only a drug therapy in an early stage. So how does that work? So if you see, there is an increased cell proliferation and adhesion and decreased cell apoptosis with Rho kinase inhibitors and cell-based therapies. So this is the mechanism of action that works. So therapeutic role would be in Fuchs endothelial corneal dystrophy and post-cataract corneal decompensation. So first successfully it was done in Kinoshita in Japan. So this was the particular molecule that was used in a rabbit model, and you can see here by day 14 how the control still has edema, and in the where the drug was used, you can see the cornea beautifully clearing up, and you can see the pupil also. Again, first human use, again also by Kinoshita group in Kyoto, and here he has done in 8 patients, only central edema, only use of Rho kinase inhibitors, no cultured endothelial cells. So this again, it has a very good role if the edema is limited to the central part, you'll have good outcomes. Next is post-cataract corneal decompensation. So this is with cultured endothelial cells. This is again Kinoshita group and 2 patients that you can see corneal decompensation that is clearing up after 3 months of therapy. So if you see previously we were taught that endothelial cells will not regenerate. So if you see this line, white line, the above is the normal endothelial cells that are there in the periphery. So below the inferior part is the new endothelial cells that have regrown after cultured endothelial cells and Rho kinase inhibitors. How do you differentiate? Their cells are larger and they have darker intercellular borders. If you see morphologically, they both are different. They are not the same. So cell-based therapy would be like an injection, as I have told you, and the patient has to sleep in a retinal position facing down so that the cells go and accumulate on the endothelium and they form this meshwork of endothelium. And in future, it will be corneal decompensations would be a simple injection into the AC and making the patient sleep on the face down. So this is cultured endothelial cells with ROCK inhibitors that I hope. But the problem would be you need robust cell culture labs, not viable for use as of now, but in future we don't know. You can get it as a sterilized human usage package. And one more interesting thing in the cornea stroma is from the Sayan Basu group from LVP Hyderabad. So what they are doing is they are taking the extracellular matrix and putting in the stromal cells into that and creating a limbal stem cell, stromal limbal stem cells, so that there is a stromal regeneration. So whenever you see a corneal scar, they mix it with the glue and put a drop over that scar. And over a period of time, because of the glue, it retains that cultured stromal cells and it penetrates the stroma and stromal remodulation happens, clearing the corneal scar. So that's the reason I'm telling in future you will not have DALKs or DMEX, only you will be doing PKs for TPK. Coming to refractive, I think femto-based lenticular procedures are already catching up and 50% of them, and it would be a preferred procedure until unless there is a contraindication. Flapless surface ablations would stay as an entry-level option for refractive surgery. We'll have better ectasia predictability because of the lot of machine learning that is happening now. You'll have more customized ablation profiles for patients, and taking myopia pandemic into consideration, next 2 decades, you will see revolutionary changes both in myopia management and prevention. So, take home message, learn basic courses in AA and ML from now, apart from your ophthalmology, learn coding. These are the 2 things that I would recommend all of you, especially youngsters. It is not away that we are going to depend more and more on these techniques. Both us and radiology, I think it should also be included in curriculum if you ask me. Thank you for your time and attention.
That was very good presentation, Madhu, about the futuristic view of the cornea practice. Now, before going to the questions, I request Dr. Ashok to go and connect your laptop so that to save the time. Madhu, can you, the incorporation of AI and ML, mostly at present we are using in the diagnostic aspects. See, what I was thinking is any equipment which is AI or compatible, then there will be a cost involved in the AI application itself. So basic equipment which can be an AI compatible. Then if you ask for an AI, so best example is the disk analysis, other things.
Pharma, we have a non-mydriatic camera that gives you an option for having an AI algorithm at an additional price. If you do, it's like an attachment. You want it, you can take it. Otherwise, you can depend on your clinical skill too. So but it is useful in mass screening.
So similarly, the diagnosis of a corneal ulcer. So if something AI option is available online, so we can use
the history and uploading the image. So by itself, it will try to give you an appropriate diagnosis. Coming to microbiology, it will be more simple that every ophthalmologist can use. Like the probes that we have showed, or a simple pregnancy test kind, lateral flow devices. So those would be more user friendly.
Like how we are using the Hill RBF formula, which is AI based, so which is now free. So otherwise, what Madhu has presented involves a lot of cost. Then, well, that translates to our patient set of population is a future challenge for us. Thank you, Madhu. You had a wonderful presentation. Now I request, as Ashok is having to catch up some flight, so I request him to start his presentation.
So good morning, everyone. So I thank the All India Ophthalmic Society and the Andhra Pradesh Ophthalmic Society, Gopal Raj sir, Madhu Udaraju, Sandhya madam, and G.R. Reddy for allowing me to take this lecture. So I'll be just sharing our works of collaborative work with engineers. So as you know, all the innovations in ophthalmology, right from phaco machine, autorefractometer, it's all not just the medical knowledge. There's so much of engineers that have worked in producing all these very useful products. So as doctors, we know we have the problems in mind, and engineers, they have the solution. The only thing is we have to just communicate with them in the right way, so that together we can bring out so many other innovations also. So as you know, there's so much of innovations happening, right from diagnostics, surgical innovations, and also daily vision care related things. And also teleophthalmology is catching up very quickly. So in Arvind, so we looked for partners. So we started having MOUs with regional engineering colleges like Vellore Institute of Technology, Indian Institute of Technology, and we were to start with, we had some discussions, and we found there were so many engineers quite interested in doing some projects, because we have the problems in mind and they all need some important problem statement to work upon. And so this started like having hackathons within our hospital. So we have been having hackathons for the past 5 years. So every year we send some problem statements. We collect problem statements from our doctors, from our ophthalmic nurses, on the problems they face every day, because we work every day. We recognize so many problems, and we just accept the problem that this cannot be altered or something. So we collect problem statements, and then we shortlist some of the important problem statements, and we give those problem statements to the engineering students. So they then distill out much shorter number of problem statements, and they start working on it for a month or so, and then we all come together on a single day, on the hackathon day. So for around 36 hours, we start working on developing prototypes for the work which we want to have. So this is I'll be sharing some of the things that we did. I think, as you know, for the squint evaluation and those things, holding the prisms is a big difficulty. I mean, having the other prism, 2 prisms together, we need to have the patient hold the prisms or something. So we didn't have a good prism holder. So then when we discussed this problem, I think there were engineers who came up one, and they developed these kind of prism holders with the help of a 3D machine. And this prism holders can hold 50 diopter prism, and also a very low power prisms also. So, and now we are using this thing, and so this doesn't need the help of any of your ophthalmic assistant or your the patient. So this is the 3D prototype, and then they take a printout, and then they make a 3D model out of it. And this fits very easily for all the diopters that we discussed. And also, I think learning the syringing thing is difficult for the beginners, for ophthalmic, and the doctors, PGs also. So we wanted to develop a silicon this thing model to know the actual way in which you have to do the syringing. So we developed it, and this was useful in the training the residents and the nurses in doing the syringing. And this is measuring a squint is always an issue. I mean, many companies, they don't invest much money because there is no much revenue out of treating squints. So we didn't have a good machine that can really measure the squint in different gazes, and we developed this model, which I'll discuss later. So what we learned is, I mean, there are so much that can be done just from 24 to 36 hours of a group work with doctors, engineers, all sit together and then do work. And it broadens our thinking. I think we are narrow-minded as doctors. I think engineers, they have a very broad mind and they can easily give us solutions. And as you know, for the pediatrics, even doing a torchlight examination is difficult. They don't cooperate to the light. And this was a simple thing. We started using a small film with a cartoon picture in it. So this makes the child much more, cooperative for the examination. And doing an indirect ophthalmoscopy is difficult even for an adult. I mean, we hold their hands, we move the finger this way, that way to do the indirect ophthalmic examination. And this is just a wrist watch with a projector, which we routinely see in the markets. So we used this as a thing to focus the child. And then we had another engineer, because you need to just keep pressing the button to have the picture on the wall. So then we had an engineer who helped us in making it on all the time, and also it had a this thing, adjustable thing, so that you can easily move around and do the examination. So so we collaborate with other engineering companies, and we have come up with many notable products like an X-Nate S-Fix and saline load sensors. And we have our own innovation lab in Madurai with a dedicated technical staff, a 3D printer, and also we have some funding support to do a prototyping product and then also patenting it. Audio.
Halls guiding the patients to their respective clinics. In the OPD, we have the eye opener to help with lid opening and retraction. We also have the eye verter to help with easy non-contact lid eversion. Our standing slit lamp helps improve posture and spinal health amongst our doctors. Let me now take you to our operating theatre and the area for administering subtenance anesthesia. Here we have LumiZoom, where the user gets better magnification and clarity for providing easier blocks. At our wet lab, we see SAFE, spring action apparatus for fixation of eyeballs to provide proper fixation,
and has eagerly decided to enroll himself into the fellowship program. Dr. Venkatesh gladly welcomes him on board and suggests that he take part in the upcoming hackathon. Akshay chooses to take up an issue that is close to his heart since his early training days: how to enhance surgical training early in one's career. He envisions a program wherein a mentor can oversee the trainee's surgeries and hand movements, even remotely, and offer support whenever necessary. Through the hackathon, with the support of his team, Akshay came up with Golf, GoPro Operations Live on Facebook, clubbed with hand movement recordings. This was to aid surgeons with learnings in their first few surgeries. The feasibility and reproducibility take the stalwarts by surprise, and they are eager to implement.
The third hackathon I went to. So I've been working on problems related to squint evaluation, and to me it was an eye-opener on how quickly engineering students could understand squint evaluation and all that is involved in the process. This is something doctors struggle with. So they came up with solutions that was way beyond what our problem statement described. So working with like-minded doctors and engineering students has truly broadened my thinking and given me a bigger horizon on what is possible.
Here, we see a healthy culture of pursuing quality research with an inquisitive mind, looking at all available innovative opportunities. The system also helps bring ideas that cater to people in need through tech and product development support. A great example would be the saline load sensor, wherein entry segment phaco machines also have sensors to warn of saline levels, avoiding surges and intraoperative complications. Our sister concern, Orolab, has taken up the idea and has incorporated the same into their latest phaco machines to bring a higher standard of care to the deserving across the world. The XNIT method of scleral fixations will further advance the field of ophthalmology while restoring sight to millions of eager eyes waiting for that one bright ray of hope.
So, so as you see in the video, it's not like many high fund gadgets. I think there are many problem statements that we come across every day. So the innovations are very small, right from the clinical care to the patient care flow or the surgical difficulties that we face. I think small difficulties that we have, I think we can easily work with the engineers. And it's good that, I mean, many forums have come and they're promoting innovations, right from ASCRS, AIOS, APOS. So all these societies, they give so much of importance now for innovation, and many innovations are receiving awards also. And even LVPI has their own startup. So the take-home message is always good to have a local partnership with engineering colleges and also or a science center or any engineer who is really interested and passionate in doing some research. And don't think any idea is crazy. Any doubt you have is crazy. You can discuss your ideas so that it comes out as a useful solution. So I acknowledge Dr. Venkatesh, Dr. Satya, and Arvind, the iCare Innovation team for this talk. Thank you.
Thank you very much, Ashok. That was an excellent innovation. This is the kind of integration which is required between, I think, the engineering section and then the medical field, especially more so in the future, like the development of the machine learning and then the AI and other features.
Yes, sir.
Sir. Thank you. Thank you very much.
Thank you.
Now I request Dr. Madhu. Anshu, you have any presentation next? Okay. Now I request Dr. Madhu Kumar to start his presentation on retinal surgeries in pursuit of the refractive outcomes emerging technologies.
Okay, good morning, everyone. At the outset, I thank Dr. Gopal Raju Garu, Dr. Madhu Raju, AIOS and APOC for this opportunity. So the topic given to me was retinal surgeries in pursuit of refractive outcomes, which are two poles apart. We retinal surgeons are, the last thing we bother about is the refractive outcome of a patient. And 10 years before, what we looked at as a retina surgeon is if somebody is CF, if he gets back a 6/60 or 5/60, our job is done. Things changed. We started looking at giving a patient 1 or 2 lines more. Say, okay, 6/12, 6/18, your job is done. But thanks to certain instrumentation changes, availability of better machines, more experience we have gathered, now our perspective has changed. So not much has changed in the retinal vitreoretinal surgical systems if you see in the last 20 years. It is just that some refinements which have happened, which we surgeons have lapped it up. So advances in VR surgeries in terms of cutters, the fluidics, visualization system, specialized instrumentation, and vitreous substitutes is what we see. So what happened with the vitreous cutters is the gauge becomes smaller from 20 gauge to now we have 25 and 27. So there is a misconception that the sutureless vitrectomy, the biggest advantage is not putting sutures. No, that is not at all the advantage. The biggest advantage of the MIVS or microincision vitreous surgery systems is it is the fluidics. The cutter open is so small and the cutter rate is such high that the turbulence which it creates is very less. And then this makes us to go very close to the retina and remove the vitreous as much as possible, where in the 20 gauge era we used to leave behind a lot of vitreous, and that used to cause redetachments, or in order to prevent that we used to put a belt buckle. So these 240 belt buckles used to create the studies have shown that they can induce a myopia of 1 to 5 diopters. So now with availability of these cutters, these innovations, we are moving away from putting a belt buckle or a serial buckle surgery alone towards vitrectomy alone. So adaptive fluidics is something which has helped us a lot, wherein we call it as IOP compensation, where you use a higher section than if you have a gravity-based infusion, the eye will collapse or the bleeding will be a little more. So what adaptive fluidics does is it will push the fluid at a higher rate so that ultimately there's a sensor in your cutter. It senses that the IOP is down and immediately the fluid is pushed in so that a stable intraocular fluid is intraocular pressure is maintained. Thanks to the wide angle visual field availabilities, now we do surgeries without assistance help in depressing in most of the surgeries, and we go almost near to the pars plana and remove most of the vitreous. What it does is it prevents the complications, the retinal detachments which happen upon when we are doing a simple vitrectomy surgeries, lesser complications and better long-term results, which has allowed us to think of doing vitrectomies in indications which were not there before. So simple vitreous hemorrhages, the floaters, patient who has an early ERM, patient who has other causes where the visual acuity is better than 612. Now we don't shy away. We do operate on these cases, and that is thanks to these visualization systems and cutters. We also have intraoperative OCTs which aid us in identifying the membranes and the planes. This is more important when we deal with the subretinal injection. The future only few things are going to change in future in vitrectomy, thankfully, compared to the cornea and the cataract surgeries. One of those will be this subretinal injection of the stem cells or the RP cells, which can be of help in treating the RP patients and the dry AMD patients. And then in significant corneal opacity patients, or when you want to go much anterior, endoscopy-assisted vitrectomy, something which is coming up, and there are papers on it. There are specialized instruments which like membrane scrapers, forceps, extrusion cannulas and needles, which has helped us to access subretinal space or meticulous removal of ILM and easy removal of membranes. Vitreous substitutes, we have gases of different concentration, SF6 and C3F8. Silicon oil comes in different centistrokes, that is 1,000, 1,300 and up to 5,000. We choose on which one. If it is a long-term tamponade needed, we use 5,000. And then compound silicon oil, like fluorosilicon oil, where you need to have an inferior tamponade. Few accessories which has made our life easy is anti-VEGF, dyes, drugs and antibiotics, which we use in conjunction with vitrectomies. So in nutshell, the impact on VR surgeries is there is a shorter duration of surgeries where we used to sit and operate for like 4 hours, 3 hours. Now we end up doing surgeries in 15 minutes to 40 minutes. Patient feels better, ergonomically our back is safe, and you have a better outcomes. Lesser complications, as I mentioned, because of the cutter and the and then the expanded indications of vitrectomy, as I mentioned, before we used to be very conservative, the visual acuity was better, now we are more aggressive. So I'll show you some videos where we have advanced our indications and how it has changed our practice. So in retinal detachment, most of the times we used to put a belt buckle or a scleral buckle along with vitrectomy. Now we have moved away from it. We do a primary vitrectomy in 90% of the patients. Scleral buckle reserved for only young patients where the accommodation of the lens is needed. In those cases, we prefer doing a scleral buckle. Still, it's important. Shorter duration of tamponade. We used to remove the silicone oil at 3 months and 6 months. And this tamponade was the one which used to create glaucoma, cataract, and the refractive issues. Now, we remove silicone oil at 3 weeks to 4 weeks. Once the laser is taken up, you don't want a tamponade there. So this is a case of retinal detachment, a typical routine retinal detachment case which we do. And you can see that the retina is just about fluttering, and in this case, it's just not the instrumentation. video is not coming here. The slide is not moving.
स्विच कर दो.
Okay, so here you can see that I'm doing a 25 gauge vitrectomy, doing a fluid exchange. The bullous retina becomes attached. Now, because of this wide angle viewing system, we are able to access an anterior break. Now you are pretty much operating on an attached retina. Tricot, blue, the dyes which help us to see the unseen membranes, and then you peel an ILM using a very fine Grishaber forceps on a detached retina, where most of the times we used to put a PFCL, and under the PFCL we used to remove. Now we peel it on without using another adjunct. So basically, all these things have made our vitrectomies much more finer, removal of much more vitreous in the periphery, no need for a belt buckle which uses a myopic shift, and this you can see that we are going very close to the retina. The base dissection is being done, which we used to leave it behind in our 20 gauge eras and support it with the belt buckle. So do an FGE laser and close it. An oil or a gas which we put is a shorter duration tamponade, where we remove it at 3 to 4 weeks. Diabetic vitrectomies, gone are those days where we used to wait till we used to call it as a non-resolving vitreous hemorrhage as an indication for the vitrectomy. No more. We do surgeries even when the patient presents with an acute vitreous hemorrhage within a week's duration. If we do a B scan, if we feel that the hemorrhage is going to cause much more problem with the traction, or it's not going to resolve, or patient needs the early rehabilitation, we go ahead and do the vitrectomies. This is because we can remove we have an instrumentation which gives us an edge, and this is, I'm showing a flat prolif vitrectomy, not lasered. This patient presented to us with a drop in the vision or just blurring of the vision of a month's duration, and you can see that we go very close to the retina, and with just cutter one instrument we're able to remove most of all these. We used to use a forceps and a scissor in the 20 gauge eras. Now you can see that I'm not using any forceps, and this is the full surgery which we could finish in 20-25 minutes with no breaks, with no need for the tamponades. So coming to the vitrectomy in patients with better visual acuity, as I mentioned, patients who have better than 612 visions, patient complaints of floaters, metamorphopsias, glare, ERM, VMT, complicated cataract surgeries, we used to wait, because during those eras, the vitrectomy chances of creating a peripheral break or a cataract was much more, but no more. What we do is, this is a case of ERM with VMT. Patient has a 6/9 vision. We have documented the worsening of his metamorphopsia, and there we go truncate the VMT and then peel the ILM around it. We call it as foveal sparing ILM peel. So these are something which, as a VR surgeons, we have developed certain techniques. We don't want to de-roof the fovea. So along with the technology, it is an experience which we have gained. It has helped us to tackle these better visual acuity patients. So this is a patient who had a post-trauma epiretinal membrane formation following the choroidal rupture. Patient complaints was metamorphopsia. So these again, we used to leave it behind, saying that anyways the macula is damaged, but now we think about patient symptoms. Even metamorphopsia or glare is more important for us. So here we go, do on foveal sparing ILM peel very close to the fovea, and then go close to that and trim it. So this patient was operated, and post-operatively patient is doing well and his metamorphopsia is gone. So this is another case of a patient with ILM hemorrhage. Patient has a 6/6 part, but he had a scotoma because of that hemorrhage. These are again indications for vitrectomy now. Just because he has a 6/6 part, we don't wait anymore, because we know that under the ILM, the hemorrhage is under pressure and it can cause photoreceptor damage. So using your back flush, just remove that hemorrhage and you're done. So this patient retains a 6/6 vision even after the surgery. This is one of the very common indications for my vitrectomies, which has a better 6/6 or 6/9 vision, but the patient complain of glare. And this is post-YAG vitreous prolapse into the AC. You can see that asteroid hyaloid peeking through it. Why is this happening? Yeah. So yeah, post-YAG vitrectomy, as I mentioned, there is a vitreous blob which was coming and the patient is complaining of glare and he had an astigmatism. All we had to do was go remove that vitreous and let the eyeball go back into its space. His astigmatism disappeared, his glare disappeared. Many of my patients which I handle in my practice is post iris claw patient where they don't do a good vitrectomy. So now you have synechiae, iris to the wound because of the vitreous which has taken it. So we remove and these patients also complain of floater. Though they have a 6/6, 6/9 vision, their quality of vision is very bad. In these cases, we do vitrectomy, release those synechiae, and now the patient is devoid of his glare and astigmatisms. So again, these are the indications which we never used to think of in our previous vitrectomy systems. Floaters with iris claw, again, this is another case where there is an optic capture and vitreous to the wound at both 6 and 12 o'clock. So here patient had a large pigments in his vitreous cavity. We remove this. Patient is devoid of floaters now. And now just clear that vitreous to the tunnel, and what was an optic capture with the glare, now you can see that the pupil constricts and patient is now given a quality of vision. So this is another case where there is a total iridocorneal touch following a leaky cataract tunnel. Again, the pigments in the vitreous which cause cystoid macular edema and your blurring that is removed, and you form the AC in these cases and do a multiple surgical PIs because these have a higher risk of going to creeping angle closure, which becomes an intractable glaucoma, and again release the tissue which was into your tunnel, and these things can be taken care. So this is another innovation which is not working. Okay, chandelier assisted eyeball reposition is what we do. Bimanual, we do vitrectomy and then we reposition it into the sulcus. Video is not working. So just last two more cases where we have intraocular foreign bodies are one cases where we want to retain the clear lens of these patients. So the days with 20 gauge vitrectomies, we used to do lensectomy and remove it through the clear cornea. So this was a case, a patient had a thorn injury and he was posted for actually cryo with intraocular antibiotics. While doing cryo, we noticed that there was a thorn which was not picked up preoperatively. So this patient had a 6/6 vision. We converted that into a vitrectomy, and you can see we go very close. This is a phakic patient. Without touching the lens, we go remove that thorn foreign body and engage it in an extrude needle and remove it. The usual way of treating this is aggressive removal of the exudates and also part of iris. Otherwise, there is a plaque and it becomes recurrence. So thanks to the newer vitrectomy instruments, we go very close, shave those vitreous exudates and remove it. So this is another case where a patient had a pencil tip injury where the anti-segment surgeon, they tried to remove it, but they could not because it was deep embedded. There you can see. And then it was taken up by us in the vitrectomy thing. Again, here the motive was to retain the patient's lens so that they have a accommodation and clear lens. Something is happening. I think there's some loose connection there. It is stuck. So sorry for this glitch. So this is, as I mentioned, again, this patient had a 6/6 part vision, early end of setting in. So here you can see that there is a pencil tip which is stuck there. Go very close to the tip and remove that capsule. This is more important because if you don't remove those exudates, they'll have an end of recurrence which keeps happening. And with an extension of MBR blade, using our phaco frag, we engaged this and then removed it without dropping it again, because to remove this, if you hold that graphite, it gets crushed and that can be toxic. It can induce a severe inflammation inside the eye. And yeah, so sometimes these innovations and using the instruments which are with you helps. So I would conclude saying that scleral buckle is still relevant. So this is a case who had a retinal detachment and patient had a trauma 3 years before. He had a foreign body sitting in his pars plana, and this was the detachment. So we did scleral buckling surgery in him, not removing the foreign body, because if I had to remove the scleral, stone intraocular foreign body, which is inert, which is sitting inside his eye, I would have had to do an extensive surgery and a relaxing retinotomy. So we chose to do chandelier-assisted scleral buckle, where you can see that there, that is the break which was there. We identified it, placed the buckle, and closed it. And this is how the patient is, even after 8 years of the surgery. Patient maintained 6/12 vision. So in summary, advances in vitrectomy and visualization system has allowed to have a lower threshold for vitrectomies, no more CF or 5/60 indications. Anything starting from 6/6, if the patient has metamorphopsia or patient comes, we take up. Lesser complications, better long-term outcomes is what has allowed us to do this. Adjuvants and accessory instruments, innovations have made surgeries faster and safer. Thank you.
Thank you, Madhu. That was a very exhaustive and excellent coverage. But one question, is there any hope for the replacement? You can talk from here.
Yes, sir.
Yeah. Is there any hope for the replacement of silicone oil?
Silicone oil replacement, we are using gas, sir.
Yeah, but not as effective as...
But silicone oil, now there are companies which are coming up with different molecules in silicone oil. Like in 25 gauge vitrectomy, when we inject, the emulsification is faster. So they're coming up with a 25 gauge silicone oil, where because they have a long silicone oil length, so when we inject through a smaller bore, it emulsifies faster. So the innovation is happening in that way. But most safe substance which is available as of now is silicone oil. Only thing is we remove it at 3 weeks now.
Yeah,
We
that's
don't wait
what
for-
main intention of mine is to, can we avoid anyway that removal once
Yes, sir. So
of the silicone oil?
yes,
Because that actually is the biggest stumbling block for your aim of 6/6 even
yes,
in
sir.
retina
True, true,
surgeries.
True. But as of now,
Uh,
we have moved to from 6 months to 3 weeks, because the complications are actually because emulsification and longer retain of silicone oil. Now we have done away with having it before the emulsification starts. We remove it.
presenter view. एक बार कनेक्ट करके बोल देना, ऐसे ऐसे कर देंगे नहीं है तो. Okay, thank you, Madhu. Now I think they have suddenly fixed my problem. नहीं आ रहा है. Okay. Yeah, switch करना पड़ेगा. Can you change there? उधर डिस्प्ले में चेंज कर सकते हैं. ऊपर डिस्प्ले में चेंज कर सकते हैं वो. Okay, I think before they fix the problem, can I request Dr. Ansu Agagli to start her presentation? Wow, change. Okay. Sorry, Ansu, I think we'll complete mine, then later on they fixed my problem. So, very good morning, all of you. And first of all, we should thank Namrata for giving us this opportunity, All India Ophthalmic Society. And also thank all the speakers from the APOS for readily coming forward and then presenting and then taking up this session. So this is, I don't have any financial interest except I'm the secretary for the society. And this is the overall scope of the presentation. So I would like to mention, see, everyone is talking about the AI and other things. Then for a simple understanding of what is AI, how it is going to be superior to the normal intelligence. See, natural intelligence, if you see, it's a learning process. So by different inputs, mainly all our senses will help us in educating and then getting the proper intelligence. So these are the aspects how we develop the intelligence. But that is a time-consuming process. The main challenge is there are several factors will influence the development of the natural intelligence, either by the nutrition or by the genetics or by the any sleep or the physical activity or environment, even the exposure. When you get a right exposure at right time, so that all makes all the difference. So with all these problems, how to overcome? So can we the process or build the artificial intelligence, or can the process be put into action? And if it is yes, then what you need? So basically what you need is basically a good sensors, like all our senses. You need a good sensors, the engineering sensors which can capture how our senses captures. So like the vision, then the sound, and then the perception. Similarly, if they have a developer sensors, so they capture the outside environment, and that will be transmitted to the central process that is called the chip. And then that is analyzed where we can develop a program then that will give you the desired output. This normally happens in our body, so we rarely recognize what is happening. Like if you see on on your left, see all the inputs, then it will be transmitted to the brain and then processed, and then the motor output will be delivered. So this is how, if you understand the natural intelligence and then the artificial intelligence, the sensor inputs they'll capture either by audio or video, and then transmission is by the nerves in our body, whereas by the semiconductors in the artificial intelligence or the mechanism. Then the software designers will develop a program where they'll capture all the input data, and then they will analyze, and then with the different algorithms, what we learned over a period of time, so they all now we publish. So now they are using that data for the simple programming, we're using by different algorithms, and then create an output which is far better than what we all do. So if you compare head to head, so human senses and the artificial sensors, then the transmission, our nerves will connect to semiconductors. They have matched that. Then all we acquired skills, they have put into deep learning. Then when all we master the skills, that they have defined into a machine learning. And then they program, and then the influence is the controlled artificial intelligence. So we are all affected by the different factors that all can be controlled very well in the artificial intelligence and the modern machines. The process can be performed in a predictable, efficient manner in a very short time consistently. So that is the advantage of the artificial intelligence. That's why everyone talks about the semiconductor industry, microchip, all these things. These are all nothing but the back end of the what we talk about, the artificial intelligence. Behind the artificial intelligence, this is the process. See, gathering the data, then the once they create the hardware, then they gather the data, and then the data preparation, then the data wrangling, and then the analysis, then the train model, and then they test those models, and then basically again they are testing on human beings. So we commit or we refine them. They're saying that this is wrong. So machine learns from that, and then they refines, and their next versions will be far, far superior than us. So the more you handle the AI, the more the AI is getting intelligence rather than we are getting more intelligent. So that is the entire process. See, coming to the applications in the cataract workflow, see this basic, I think, if you now want to apply on the cataract, right from the outpatient, from the diagnosis and then the decision making, counseling, biometry, image guided surgery, phacoemulsification, and post-op outcome analysis. At every step, we can incorporate the AI-based models. So this is in the pre-op evaluation. Now we have the wavefront analyzers where we can, sometimes we'll get a doubt whether the visual loss is corresponding with the media changes and with the normal macula. Or sometimes patients complaining of severe blurring, but if you see there will be 6 and hardly any cataract. Now we have the equipment where we can analyze, that is called the dysfunctional lens syndrome. It scores from 0 to 10. The lower the score, the more the disturbance. So with this, the gadgets, we can confidently advise the surgery. Then next comes the counseling. So we can, they have developed an excellent models where we can give the checklist to the patient. So they can, like all those symptoms, expectations, they can feed into that program. So finally it will tell both surgeon as well as for the cataract patients what IOL they will choose. From surgeon side, what is the precaution we should take, what is the realistic expectation we can get. All these things can be utilized in the AI model. Anyhow, we all know it is very well time tested, the Hill RBF AI integrated model. The results are far, far superior than the SRK and SRKT, Barrett's and all those things. Then next comes the incision image guided surgery. So there are excellent tools, digital imaging, where it captures the images in the pre-op. Then you can see on the left side with the arrow that continuously gauges the movement of the eye, and then it will even guide us how far we can go for the capsular excess, whether we are in the right size or not. So that also helps in the IOL axis placement and then IOL centration and other aspects. This is in the image guided aspects. Then comes the chamber stability. And when it comes to the surgical aspects, now their Centurion machine has got the active centric fluidics, where the sensors are placed right in the phaco probe. So very near to the chamber, in fact into the chamber. So even the shortest time, they'll capture the fluctuation in the chamber, and then the mitigation will be done immediately, the corrective measure. See, if you can see here, 8 times the probe has detected and then corrected itself and prevented it being happening. So this is the kind of sensors which they have developed. With that input, with the software design, they can go to a mitigation prevention. Now what I was suggesting them is, let us incorporate the same thing in the phaco delivery system. When we are using an energy or the power, So with the foot pedal, so the kind of resistance it gets, the machine should capture, and the average amount of the energy which you are using. So machine should calibrate and then tell us a warning that this is the because it is very difficult to predict the hardness of the lens or the stickiness of the lens unless you directly phaco it. So very only 70-80% of the time only we can predict the hardness before surgery. Actual fact will be known during the surgery. So this, if the machines can capture that feedback by highlighting this phaco delivery, so then it can change automatically to the next mode, and then it performs the surgery. So this is what I was suggesting them. They promised me that they'll incorporate this in their new model. Similarly, in the visco evacuation, at the end of the surgery, the biggest challenge is how completely you can remove the viscoelastic. So viscoelastic causes the postoperative raise in IOP, and in spite of doing a good surgery, now especially nowadays, most of them are the daycare surgeries. So in the middle of the night, you will get a call saying the severe pain. So then what I try to do is I'll use the vacuum settings at the end of the nucleus removal. So at that stage, the anterior chamber will be filled with the BSS. So that is the basic vacuum, which the resting vacuum for that eye. So at the end of the surgery, after inserting the lens, then I'll again put right now if you put the IA probe, then it may not match the output. Then I'll use the same, I'll pause here. Yeah, I'll use again the phaco probe and see that the vacuum setting which I got at the end of the nucleus removal should match the vacuum setting at the end of the viscoas. Till I continue the aspiration till I get the post nucleus removal vacuum setting. So that assures me that the anterior chamber is now the vacuums or the status, the resting vacuum will be similar to that of the eye filled with the BSS. So that indirectly assures me that the viscoelastic is completely removed. Now they are developing this model into their new Ingenuity viewing system, where it can even capture the viscoelastic viscosity movement as the shadow. So then they are incorporating that into their new model. To summarize it, see, natural intelligence, it's a time consuming. That means one has to grow 20-30 years to develop the intelligence, complete wisdom. And it's variable from individual to individual. And then the artificial intelligence is hardware and software is ready now. It can overcome the natural intelligence shortcomings, and it can be applied to the medical field especially, and then from diagnostic to procedures. That will improve the safety and outcomes, and it can improve the standardization of the care. So take home is artificial intelligence is ready, and it's a reality, and it can be applied to the cataract surgery patients at all levels, and it will definitely improve the safety and outcomes and standardizes the care. Thank you very much.
Sir, I have one question for you.
Yeah, right.
Excellent talk. It was really nice to hear those things from you. So with all this AI taking up and things, so where do the cataract surgeons stand? So you'll always need a cataract surgeon to use these things, or day will come where the robotics will take over?
So recently when I was, I met one of the surgeons group while I'm traveling back. They're all coming back from a conference of the robotics surgeries. what I heard from them is now they have gone far ahead of the robotic surgery, and the main the hindrance or the block is the cost of the instrument, robotic instrument, and only that Da Vinci or one company is making it, which is only US, and it cost almost in 10 to 12 or more than 12 to 13 crores. Now with Make in India movement, and then once the patency is over, now 2-3 companies from the India, so they developed a robotic model. And they were, it seems the main machines and then the other things are in Bangalore. And then that can be accessed online to even to Rajam and Srikakulam and in the remote places. And they were all cholecystectomy, everything. So they will buy an Indian version, and that can be, actual robotic surgeon can be there in Bangalore and other things. So it makes very easy for them. So similarly, all these, once if you develop an AI model and then the machine learning model and then the robotic options, then things will change. But coming back to your question, and I always tell the people that AI will never replace the human beings. AI, what I see is, it will help us to deliver our result in a faster and much superior, like 10 times, 20 times, 30 times the better than what I do. So coming back to your question, still I will be a cataract surgeon and cataract surgeons will be there. But what I am producing the result. So with the AI, the future generation can produce 20 to 30 times better than what I am producing now. So I think I answered your question.
Yes, sir. Thank you.
So, and at the same time, the reality you should know is patient expectations will improve by 30 times. Like how the retina surgery has shown us the expectation. So we will always be trying to catch up the patient expectations in future. Still, our condition will be the same. Only thing, the way we do will be better than what we are doing now. So that's the only thing. The best example is your retinal surgery.
Yes, sir. Yes, sir. I agree.
Because I am the person who has seen assisting the dissection, putting the implant, and then SRF drainage,
Yes, sir.
dry tap, bleeding, next day not attaching. But now if you see, sometimes the retina surgeons are finishing faster than my cataract surgeries.
Yes, sir. It does happen.
Thank you, thank you.
Thank you, sir.
Now I request Ansu to start her lecture. So next session, please excuse us. Actually, they have given 45 minutes late to us, so we'll hand over.
Thank you, Dr. Gopal Raju, Madhu, and Andhra Pradesh Ophthalmic Society for this opportunity to present in this forum. Yeah, so I shall be presenting on the recent advances in ocular oncology, what we are doing new in the last few years. So I have divided my talk into 4 parts: eyelid, ocular surface, orbit, and intraocular malignancy. To begin with eyelid, I will be taking you through a series of cases and and sharing the knowledge learned. So this particular girl, 6-year-old girl, the right eye, she presented to us with ocular surface squamous neoplasia with orbital extension. You can see that we had to enucleate the eye, and that's customized ocular prosthesis that the girl is wearing. But what I want to focus on is that the child has xeroderma pigmentosum. So there were multiple squamous cell carcinoma which used to pop up from different areas of her skin, and you can see that skin grafting, excision biopsy skin grafting has been done, and there are new lesions coming up from the edges of the skin graft. So for this patient, we resorted to the use of imiquimod cream once daily for 2 months, and the lesions, the superficial lesions, were taken care of. So topical imiquimod is freely available, cheap, and is a good option for multiple superficial squamous cell carcinoma or basal cell carcinoma in such patients with xeroderma pigmentosum. So apart from imiquimod, 5-fluorouracil, photodynamic therapy, targeted therapy with vismodegib or sonidegib has been reported in literature, but in developing country like ours, this hedgehog pathway inhibitors are not available. And the use is also restricted because of the expense and the fact that there is recurrence on stoppage of this medication. However, the tumor-free span has been reported to be around 80 to 90% for a period of 3 months. Moving on to neoadjuvant chemotherapy for eyelid tumors. Earlier, for sebaceous gland carcinoma with an orbital extension like this, the only available treatment in our armamentarium was orbital exenteration. However, now we have a fairly established protocol for chemotherapy consisting of cisplatin and 5-fluorouracils. We chemo reduce the tumor, and once the size is reduced, we do a eyelid sparing procedure reconstruction, like you can see in this particular patient. Eyelid sparing procedure was performed in this case of an extensive sebaceous gland carcinoma. MAP biopsy for sebaceous gland carcinoma. As you all know, pagetoid spread in sebaceous gland carcinoma is reported in literature to the extent of 16 to 80%. Earlier, the training was that whenever we used to see clinical signs of MAP biopsy like diffuse conjunctival congestion or a diffuse thickening of eyelid, loss of meibomian gland architecture, loss of eyelashes or a surface telangiectasia, we used to go ahead and do a MAP biopsy. But recent literature from our center shows that we will miss 10% of cases of pagetoid spread if we just go by clinical diagnosis. So it is best that we perform MAP biopsy in all patients of sebaceous gland carcinoma and then go ahead with a protocol based management for eyelid tumor. So we need to look in, just excision biopsy for eyelid tumors doesn't suffice. We need to look into the histopathology report and into the risk factors, perineural, intraneural, vascular emboli, and if any of these are there, an EBRT needs to be considered. Fixed frozen mismatch is also a possibility for these patients, and if there is a margin positivity after reconstruction, and if it is lamellar, consider cryotherapy. If it is full thickness, consider radiation. So MAP biopsy positivity, if it is localized, topical mitomycin C and cryotherapy are options. If it is diffuse, orbital exenteration needs to be considered. All patients with eyelid tumors, regional lymph node assessment is a must, and if there is a metastasis, radical node dissection and radiotherapy needs to be clubbed to the treatment. Moving on to ocular surface tumors, so there has been a paradigm shift in the management of ocular surface squamous neoplasia. Earlier, the no-touch surgical excision with cryotherapy was the standard of care, but now again there is a lot of evidence that topical chemo and immunotherapy should be the first line of treatment. As we all know, ocular surface squamous neoplasia is a clinical diagnosis where we see a limbal nodule with corneal involvement and intrinsic vascularity with the feeder vessels and surface keratin, and on AIOS the diagnosis is confirmed with the presence of the thickened hyperreflective epithelium with an abrupt transition. The drugs which are available are mitomycin C, 5-fluorouracil, interferon alpha 2b. Most commonly used are 5-fluorouracil and interferon alpha 2b, and so we immunoreduce, immunoprevent, and do immunomodulation. I will come to each of them. To reduce the tumor size for extensive OSSs, definitely topical immunotherapy is the drug of choice, like this diffuse placoid tumor or more than 6 clock hours of limbal involvement, like you can see here. So immunotherapy works wonders for this. For these type of patients, you can see this is pre and this is post. The entire ocular surface is free of the disease. It can be used for immunotherapy in cases of corneal OSSN where otherwise alcohol keratoepitheliectomy, which we used to do earlier, used to result in corneal scars. For small tumors, recurrent tumors, and post-PK patients, again, this is the drug of choice. So immunoprevention, whenever in the histopathology you see a margin positivity, consider 3 cycles of immunotherapy in the post-op period. And it is very important to understand when not to consider topical therapy when the diagnosis is in doubt. Like this particular patient was diagnosed as OSSN, but it is not a case of OSSN, it's a case of eyelid sebaceous gland carcinoma with a pagetoid spread. So whenever in doubt, go ahead, perform an incision biopsy, establish your diagnosis, and then go ahead with topical immuno or chemotherapy. So whenever the depth is in doubt, like this particular patient with scleral fixity, you can see on the UBM the anterior scleral layers are involved. Don't consider immunotherapy. Go ahead and do a surgical excision with a lamellar sclerectomy. So whenever there are signs of scleral invasion or intraocular extension, like deep corneal invasion, AC cells, secondary glaucoma, corneal perforation, topical immuno or chemotherapy is not possible. You need to go ahead and perform surgery. T3 stage, that means involving the adjacent structures, like in this particular patient, you can see caruncular involvement, punctal involvement, eyelid involvement. Then again, topical therapy is not of choice. Whenever the patient compliance is doubtful, you can't consider topical immunotherapy, and routinely it shouldn't be given. It should only be given if there is a margin positivity post-surgery. Something again new, a new kid on the block is the laser photocoagulation for benign conjunctival tumors. We are using laser photocoagulation, like in our center we use yellow laser, the same laser that our retina colleagues are using for photocoagulation. And this is how the visual changes appear: first graying, cavitation, blackening, then we can remove with bud. And you can see for such large tumors as well, of course these are benign tumors, so you can see it has nicely resolved without any tissue dragging, which is the case with surgical excision. Plaque brachytherapy for conjunctival tumors. This patient of leiomyosarcoma, post-excision plaque brachytherapy is a must to reduce the chances of recurrence. Similarly for OSSN, whenever there is a base positivity, like in this particular patient in the post-op period, you will have to consider, there was a base positivity here on the histopathology, you will have to consider giving the patient plaque brachytherapy. We have recently started in our center. It requires a lot of licensing, so we have done that and have started plaque brachytherapy. Moving on to orbit. So 12-year-old child came to us with the left eye bulging out in the past 3 days, and there was a history of preceding upper respiratory tract infection. So this is a typical case of venolymphatic malformation. Further on CT scan, you can see ill-defined multiple cystic masses, which is transcompartmental with multiple air fluid levels. So this is nothing but a venolymphatic malformation with bleed, what we earlier used to call as a chocolate cyst. So we did a blood aspiration with bleomycin sclerotherapy, and this is how she was in the post-op period. So sudden intraorbital hemorrhage in a child, think of venolymphatic malformation and treat with bleomycin sclerotherapy. Again, for vascular orbital tumors, like this particular lady, 57-year-old, came to us with this large palpable inferior orbital tumor, which was causing a lot of indentation on the globe, choroidal folds, tortuous vessels. In the MRI, look at these flow voids or the vascularity of the tumor which is there. And we reviewed the previous records and found out that the patient has already undergone an orbitotomy at a different center, and there was torrential bleeding on table, which required the surgeon to use all possible forms of hemostasis. However, the surgery had to be abandoned because the bleeding could not be stopped, and the incision biopsy showed this to be a solitary fibrous tumor. So we have a hypervascular solitary fibrous tumor causing mass effect. There is an attempted surgical excision, which we know from our knowledge of literature that is a known risk factor for malignant transformation. So what do we do now? So we did, the options were radiotherapy and embolization. We did an embolization because it's a targeted form of therapy, saves time and allows immediate surgery. So with along with the help of our interventional radiologist friend, we embolized this feeder vessel, and you can see the vascularity grossly coming down, and we could safely do a surgery at 1 week after 1 week of the embolization procedure. And this is at 5 years follow-up. So, in collaboration with interventional radiologists, preoperative embolization is a very safe procedure for hypervascular orbital tumors like solitary fibrous tumor or alveolar soft part sarcomas. Again, in the I want to show this particular patient intraconal run-of-the-mill orbital mass. We did a cryo extraction on day 1. The vision was NPL, and so we are very prompt in publishing our complications. So we published this particular patient, and you can see there's an ophthalmic artery occlusion with a cherry red spot there. So keeping this in mind, we need to understand, like this lady, 39-year-old, best corrected visual acuity 20/20 in both eyes. She just came to us because there was a visual blur in the left eye. And what do we see here? In the MRI, we see a highly enhancing small mass abutting on the optic disc, causing this disc edema. This is nothing but a cavernous hemangioma. So we considered IMRT, stereotactic radiosurgery is the term we use nowadays. And proton beam should have been the best possible treatment, but the availability is very less and it's very expensive. So we went ahead with a stereotactic radiotherapy. So for stereotactic radiotherapy, earlier it used to be an invasive BRW frame to ensure that the eye doesn't move. Then we moved on to non-invasive GTC frame, but now things are very easy. We just use a brain aquaplast onboard imaging, and you can precisely target the radiation to the tumor, and that's why it's known as a stereotactic radiosurgery. So that's what we did for our patient, and this is how post IMRT you can see the visual field defect has come down. The optic disc edema is also gone. So stereotactic radiosurgery is a good option for apical tumors, one-eyed patients, recurrent tumors, optic nerve sheath meningiomas, and a good rapport with your radio-oncologist helps. The last part of my presentation, intraocular tumor. So intraarterial chemotherapy, this was again a paradigm shift from intravenous chemotherapy, and globally this is the standard of care, but not for us in India, because each session cost us around 2 lakhs, and you need people who have expertise in the procedure. So though it's an established technique, it's expensive, does not take care of the systemic micrometastasis, and the complications are devastating, like ophthalmic artery occlusion. So the technical expertise is of utmost importance. So this is the protocol we use at our center, triple drug regimen. This was the first intraarterial chemotherapy we did in the state of Andhra Pradesh. It was a collaboration between interventional radiologist, pediatric oncologist, and so basically what we do here is we go through the femoral artery, and microcatheter is introduced, which goes into the common carotid artery, from there into the internal carotid artery, and we stop at the ostium of the ophthalmic artery. From there, the chemotherapeutic drugs are injected slowly. So it's a triple drug regimen. If you use more drugs, the number of sessions will come down. As I said, it's a very costly procedure. So the drugs are injected very slowly, and they go into the ophthalmic artery circulation and effectively reduce the tumor. So this is again a patient post primary intraarterial chemotherapy. You can see of retinoblastoma, which has completely resolved. Intravitreal chemotherapy is again absolutely a game changer. Earlier in our residency days, the traditional teaching has been you can't go into an eye with retinoblastoma. There are chances of spread of tumor cells, but with the Francis Munier group coming up with this particular type of chemotherapy, and it's absolutely, as I said, it's a game changer for patients with vitreous seeding in retinoblastoma. And the site is being marked. We are injecting topotecan slowly, 30 microgram in a 0.15 ml, and withdrawing the needle should be through the cryo ice, and then you need to do a triple freeze thaw cryotherapy at the site of injection, just to ensure that there's no tumor cells left behind. And this is followed by jiggling of the globe to ensure that the drug is distributed equally in the vitreous cavity. So safety enhanced intravitreal chemotherapy is what we do. As I said, choosing a safe site where there are least vitreous seeds, thin gauge needle, 30 gauge ideally, exit through the cryo ice, and then a triple freeze thaw cryotherapy. Death by water means just flushing with distilled water, so that even if there are tumor cells there, they are washed away. You can also raise a bleb of subconjunctival topotecan. So earlier we used to use intravitreal melphalan, but there were a lot of side effects, the most important being these pigmentary retinopathy. So we have now completely moved to intravitreal topotecan with no retinal toxicity with enhanced efficacy. So again, this is one such patient where we used a bilateral patient where we were able to salvage the left eye only because of this modality, intravitreal chemotherapy. Intracameral chemotherapy is again something very new which has come up, and for treating aqueous seeding in retinoblastoma, but the choice of cases is very important. This is one such case where we effectively, with the help of intracameral topotecan and intravitreal topotecan, a combination, we were able to achieve tumor remission. The last patient, this child with retinoblastoma, we were continuously facing a difficulty where the PMMA implant was going and settling into the inferotemporal quadrant, and twice the implant exchange was done, but as the Tennant's capsule was not there and the fibrous septa was missing in the inferotemporal quadrant, every time it was going and settling in the inferotemporal quadrant. So the options in such patients are implant removal with dermis fat graft, but we did something very new, that is we created and fabricated a customized orbital 3D implant which was fitting, as you can see in the CT scan, it is just fitting in the inferotemporal quadrant. This was made with the help of the DICOM images of the CT scan, from where a 3D orbit was created, and in that orbit the 3D implant was fabricated. So these patient-specific implants is again the way forward for such complex cases, and we were able to place a customized ocular prosthesis successfully. Thus, to conclude, eyelid, we talked about targeted therapy, neoadjuvant chemotherapy for sebaceous gland carcinoma, map biopsy, having a strict post-operative protocol for ocular surface, understanding noduloulcerative OSSN, the laser topical immunotherapy, and the indications where we can't use them, laser photocoagulation for benign lesions, plaque brachytherapy, for orbit, gliomycin for venolymphatic malformation, performing a preoperative embolization for hypervascular orbital tumors, radiotherapy for intraconal apical tumors, intraocular, intraarterial chemotherapy, intravitreal, intracameral chemotherapy for retinoblastoma, and customizing for each patient for the best possible outcome. 3D printing of orbital implant is the way forward. Thank you everyone for a patient listening.
That was an excellent presentation, Ansua. Thank you. Any questions? Okay. Thank you all. I thank all the panelists today. Thank you. I'll hand over the session to the next one.